everyone, and welcome to Occupational Therapy 236, OT with Youth. My name is Melisa Kaye, and I'll be your instructor today. Today's topic is something of a continuation of our exploration of mental health diagnoses, and it is an overview of mental health concerns for youth, building on what we learned about schizophrenia and other psychotic disorders in our last session. Let's go ahead and get started. First, a brief trigger warning. This information can be upsetting to some, either because you are experiencing some of the conditions or symptoms, or because your loved ones have. So my urging is to please take care of yourself. Either pause the recording and come back to it, or take it in little doses. Also, if you're really experiencing some difficulty with the content, please contact me and let me know, and we will work something out. Also, get support as needed, either by contacting me or other faculty members, by contacting your support system, mental health professionals, on-campus mental health services, or your general support system. So please do take care of yourself. I'm here for you as well as others. And also be reminded that we will be dealing with folks who have mental health conditions in our practice, whether we're in mental health or not. So knowledge in this case is power as well. So I encourage you to take in as much of the information as you can, and then let's figure out how we can support you with the rest. All right, moving along now. We have 3 objectives. First is to look at the DSM-5 diagnostic groups and those in particular that affect youth, to identify occupations that are most compromised for our youth that have mental health disorders, and finally looking at the role of OT for individuals diagnosed with mental health disorders. Now, one caveat: there are so many mental health disorders affecting youth, and this, as the title says, is an overview. It's a high-level overview, so we could dig into any of these topics and talk at length about it, but today is just an introduction. So please bring your questions to class, and if you're particularly interested in one or more diagnoses or conditions, just let me know, and I'm happy to give you more resources to support your learning. We're going to start with a DSM overview, and this is 3 slides of mental health diagnoses taken from the DSM-5, and I'll also let you know what we're going to cover today. In terms of categories, the neurodevelopmental disorders are typically diagnosed in children because they're often present early in life, so we won't be going into that. We looked at schizophrenia and other psychotic disorders in our last session. So today, bipolar disorder, depressive disorders, anxiety disorders will be on our list. We're going to skip over obsessive compulsive and then land on trauma and stressor-related disorders. Does this mean that obsessive-compulsive disorder is not important? No. We're simply doing this for the sake of time and brain power, and again, I'm happy to dig into any of these diagnoses as you would like. So just reach out to me. I'm happy to go there with you. All right, page 2 of 3. We're going to then land on feeding and eating disorders, and then skip down to gender dysphoria. As you can see, there's a whole bunch of other disorders listed, which we will not deal with today. And finally, the 3 that we're going to look at on this page are disruptive impulse control and conduct disorders, substance-related and addictive disorders, and then a brief foray into personality disorders. Something to keep in mind is that in addition to the diagnoses in the DSM-5, we have something called V codes. These are supplements to a primary diagnosis, and they often point to either an environmental component of the diagnosis or something that's happening psychosocially. So things like child physical abuse, difficulty with siblings, housing problems, things like that that would complicate the primary diagnosis and are good to know about, but don't actually comprise a diagnosis in and of themselves, are called V codes. This is a mind map of all the categories of mental health diagnoses. The ones in gray are the ones that are not really being addressed, or not really so much linked to youth as some of the others. And it's a bigger list than the one I just went through, but it's also just a way for you to see on one page all of the diagnoses in the DSM in one place. So why pay attention to diagnoses? We know that especially with mental health diagnoses, they're difficult to diagnose. They often get mistaken for one another. At the end of the day, occupational therapy is a functional profession rather than a diagnosis-driven profession, meaning that if someone has schizophrenia or bipolar disorder, if they have a functional challenge or difficulty, say in the area of work or education, so productivity, we will treat that individual regardless of their diagnosis. And their difficulties may be very similar. So why do we want to know about diagnoses? Well, it's one way to very quickly gather information to inform treatment. So if we have a schema or a brain map about major depressive disorders, we can quickly pull into our therapist's brain features of that disorder and get an idea, just a hypothesis, about what the client may be going through. Now, we're definitely going to need to check that out through evaluation and an occupational profile and observing the client directly, but it gives us a leg up and an idea of where we might be going. So it's not the end-all be-all, but it is another tool in our toolbox. The other reason is that it informs the evaluation and intervention process. If we can identify some of the potential problems, then we can go on to strengths and goals and providing treatment. Again, we're not going to rely on the diagnosis to tell us what's up with a client. We're just going to use it as a starting point. And then we can most successfully complete the evaluation, look for things that may be left out that are not included in that particular diagnosis, and move on to goal setting and treatment. Some important considerations across diagnoses. The possibility of misdiagnosis. So a lot of disorders tend to present in similar ways and the symptoms can get confused. So we always want to be aware of that. We also want to be aware of co-occurring disorders, also known as comorbidity. And I was just finishing updating the slide deck and looking at substance abuse disorders, and there's a huge amount of comorbidity in that category. So this is an example. One can be drinking or using street drugs to mask anxiety, to mask depression, to mask a nascent psychotic symptoms of potentially a first psychotic break in schizophrenia. So this co-occurring really complicates things, and we want to be aware of it so that we're most effectively treating our clients. Also, psychosomatic symptoms, so symptoms that are going to arise in the body, in other words, soma, meaning of the body, that may affect the individual are important to note and to take seriously and address with the client, even if it's not the OT that's ultimately going to be addressing it. We want to be a segue or a bridge for that person to get the help that they need. And there is finally a double bind of diagnosis. So on the one hand, many treatments require a diagnosis, especially with regard to payers, right? So how are you going to get your treatment funded? You're going to get a diagnosis. However, there are also many negative consequences of diagnosis in the form of stigma. So once one is labeled, that can be really damaging to them. There's just the sort of general in the Western world stigma of mental health diagnoses. And then there's some additional culturally mediated stigmas that may occur where mental health diagnoses are reviled or seen as dangerous or frightening. So we want to keep that in mind as we're working with folks who have mental health diagnoses. All right. Our first foray is into bipolar and related disorders, and what you're going to find is that I'm going to go through the kind of the same approach and structure of introducing the diagnosis. Again, we're not going to go into depth, so know that you're not getting all the information. You're getting a high-level overview. Then we will look at what OT can do, and then we'll move on to another diagnosis. So these will be in some chunks, and and we'll also put them in some separate videos for you. All right, so bipolar and related disorders. Basically, bipolar disorder is characterized either into bipolar 1 or bipolar 2. Now, the defining feature of bipolar disorder is that there is a cycle of mania or hypomania, and hypomania means shorter lasting. So manic episodes or hypomanic episodes alternating with depressive episodes. So it's a cyclical disorder, and the person alternates between these two states. So mania is sometimes confused with like giddiness or happiness, and it does have that quality sometimes, but the person's mood is very abnormally and persistently elevated. They may be expansive. They may also be irritable or goal-directed, have a ton of energy, not really sleep. They could seem happy and engaged, but it's got this quality that's frenetic and does not match with what a typical individual would be doing or expressing. There can also be some grandiosity associated with it. Folks that I've worked with have spent thousands and thousands of dollars while they're in a manic episode, or made giant worldly plans that never actually come to fruition, but they're part of the mania. So with bipolar 1, the manic episode has to last at least a week. So that's the definition of a manic episode. And there's also hypomanic episodes lasting at least 4 days that could be in bipolar 1, and then major depressive episodes. So what does that look like? A depressive episode, it has at least 5 depressive symptoms, and we'll see what those are when we talk about depressive disorders, but they include things like a depressed mood, a loss of interest or pleasure. It could also be insomnia or hypersomnia, so the person doesn't really want to get up and just wants to sleep all the time. Also, weight change without trying. So some of it is very mood related, and other is more somatically related. So in bipolar 1, as I said, mania and depression alternate. And then bipolar 2, the only difference is that there's a hypomanic episode, so a shorter duration episode of mania, no manic episode. So the manic part cannot be a part of bipolar 2. That's the definition of it. And then again, there's depressive episodes. These cycle in people at different rates, different times. Sometimes the person won't be either manic or depressive. They'll just be kind of more on an even middle keel. And there's a lot of different specifiers, which again, we're not going to go into detail today, but they include things like mild, moderate, or severe episodes. Also, they can include psychotic features. They can have anxious distress associated with them. They can be rapidly cycling, and a range of other additional specifiers. The lifetime risk of suicide for folks who have bipolar disorder is 15 times that of the general population. So suicide risk is huge in people with bipolar disorders. Other things to note are another diagnosis in this constellation, which is called cyclothymic disorder, and that is simply a kind of a lower level, not as intense and not as acute as the levels that are present with bipolar disorders, but it is a cyclical hypomania and depression, and possibly mania. I'm not sure about that. But it's a lower level. So the person doesn't qualify for full-on bipolar disorder, so they may be diagnosed with cyclothymic. And then bipolar disorder may be induced by medications or substances, so we want to keep that in mind. Areas of occupation and performance that are compromised: pretty much everything. And you'll see as we go through the slide deck that I'll ask you to think about what areas of occupation and performance are primarily compromised. And what we'll see is that in our youth, many areas are compromised. So it's a little bit of a trick question there. Treatment strategy and the role of OT. So the other thing to note is that as we go through this slide deck, we're going to see what is the range of treatments, and then where does OT slot in with treatment in terms of what our scope of practice is. So cognitive behavioral therapy, which is an active, problem-oriented intervention that seeks to change maladaptive beliefs, attitudes, and behaviors that contribute to emotional distress, and that's from your textbook, Brown 2019. That's the definition of cognitive behavioral therapy. We're going to be looking at it in depth when we look at some of the OT-related interventions in an additional session. But cognitive behavioral therapy is one way that OT can work with folks with bipolar disorder. Also, psychoeducation, peer support, and either running those programs or hooking folks up with them, helping to support employment and engage in supported employment, establishing meaningful routines so that that person has more of a routine and a daily set of rituals and habits, and then help with medication management. So medication is often the frontline treatment for bipolar disorders, and it is to even out those manic and depressive episodes. And one of the problems with treating this disorder, difficulties with treating this disorder, is that the medication often creates in the person a lack of either highs or lows, which can be disturbing, and the individual actually wants to experience the mania. And so medication management can be key for us in helping to keep the person on their meds so that they can achieve a higher level of functioning.